I will tell you why almost all patients with severe hyponatremia need a slow correction. There are some exceptions, though. If you have a patient who obviously was normonatremic just a few hours ago and who now has a hyperacute hyponatremia with symptoms, then you don't need to care about slow correction rules, just correct the hyponatremia quickly. Otherwise, all patients with severe hyponatremia below 120 should have a slow or very slow sodium correction. This is my list of conflicts of interest. It's a short list, nothing. I have a strong feeling that we are replaying a biblical event. I'm just a poor boy from a remote little university from the very edge of the known world, whereas my opponent is the top expert in the field, with a reputation that he's able to crush his opponents. But we all know how it ended the last time, so I feel very confident. But, Mervyn, have no fear, I will show mercy. Hyponatremia is common. According to a paper published in the New England Journal of Medicine just 5 days ago, it affects 1/3 of hospitalized patients, of course, somewhat depending on the hospital's patient case mix. It's also very difficult. According to some authors, it is, of all electrolyte imbalances, the most difficult one to understand and to manage. It's not benign. There is substantial mortality associated with hyponatremia. According to one recent study, in-hospital mortality ranges from 6 to 10% in patients with severe hyponatremia. Mortality is higher among patients admitted to intensive care. These are some data from the Finnish National ICU Registry. We have some 400,000 admissions since 1998. And you can see in blue the proportion of patients admitted with severe hyponatremia below 120. The proportion has gone up from roughly 1% in the late 1990s to 2% nowadays. The orange curve shows those patients with even more severe hyponatremia below 115, and the grey curve those below 110. But roughly 2% of all our ICU admissions have severe hyponatremia, and there is substantial mortality associated. Here we have hospital mortality of our ICU patients in Finland since 1998 to 2021. The blue curve showing the mortality of patients with normal sodium concentration, and the orange curve showing mortality for patients with severe hyponatremia. So patients with severe hyponatremia are actually as severely ill as general ICU patients in terms of their risk of death. Interestingly, though, those patients with the most severe hyponatremia, that is those with sodium below 115 in orange, or those with sodium below 110 in grey, have actually slightly lower mortality than all severely hyponatremic patients, perhaps because these patients with the extremely severe hyponatremia are often admitted to our ICUs because of that hyponatremia, whereas a patient with, let's say, sodium 118 often has multiple other problems as well. Nevertheless, hyponatremia is dangerous, but its rapid correction is extremely dangerous. There was a very interesting study published in 1981 in Science, written by Kleinschmidt, De Masters, and Norenberg. They made a very fascinating study demonstrating nicely that in rats that were treated with hypertonic saline after 3 days of vasopressin-induced hyponatremia, demyelinative lesions emerged in different parts of the brain. So these rats were first made hyponatremic with a hypertonic solution, 2.5% dextrose in water, and with repeated subcutaneous injections of vasopressin over a period of 3 days. They ended up with a mean serum sodium of 106 millimoles per liter, meaning severe hyponatremia. The normal value in rats is precisely the same as in humans. After this induced hyponatremia, these rats were given hypertonic saline at a concentration of 1 mole per liter, which means roughly 6% sodium. And that was given intraperitoneally, quite a large dose, 2 mL per 100 grams of weight, meaning 20 milliliters per kilo. And as a result of this treatment, these rats had a mean sodium of 152 millimoles per liter. So after induced hyponatremia, an aggressive treatment to correct that hyponatremia. These are histopathological findings. It's a cross-section of the brainstem thalamic junction in the rat. A special staining has been used to make demyelinated lesions visible. These pale areas are demyelinated, whereas this is how a normal control looks. So obviously, there was severe neurologic damage caused to these rats. What makes this study even more interesting and fascinating is that they had control groups as well. And no demyelinated lesions were found in the control rats. There were 2 groups of controls. One group that was induced hyponatremic using exactly the same protocol as used in the experimental group. So 2.5% dextrose in water and then subcutaneous vasopressin to induce hyponatremia. And actually in this control group, these rats were even more hyponatremic. So the mean sodium was 100, severe hyponatremia. However, no measures were then taken to aggressively correct this hyponatremia. Instead, the rats were allowed to self-correct by free access to food and water, and no demyelinated lesions in the brain. Then there was another control group that was made hypernatremic with hypertonic saline, but starting from a normonatremic baseline. So there was no preceding hyponatremia and no brain damage in this group either. So the conclusion is pretty clear here. Hyponatremia per se does not cause severe brain damage, and inducing hypernatremia from a normonatremic baseline does not cause brain damage. But aggressive treatment of hyponatremia is dangerous, causes severe brain damage. This is in rats. What about humans? 1 year later, Norberg and colleagues published a paper on 12 patients who had had severe hyponatremia and who had developed central pontine myelinolysis. All these patients had had a rapid correction of their sodium level. In addition to that rapid correction, 11 of these 12 patients had achieved a serum sodium of at least 147 millimoles per liter. And the conclusion of the authors is that central pontine myelinolysis may be caused by too rapid or too excessive rise in serum sodium from a hyponatremic baseline. This figure shows the correction rate in these same patients. So in the gray bars here show the mean correction rate over the days in those patients who had neurologic lesions, whereas the white bars show the correction rate in patients that had no neurologic damage. And as you see, the mean correction rate was very close to 20 millimoles per liter per day in these patients with neurologic damage. Some years later, another group published a study on some 30 patients, a prospective study. These patients had severe hyponatremia, mean 108 millimoles per liter. And they actually had quite a rapid initial correction rate, slightly even exceeding 1 millimole per liter per hour. However, only to mildly hyponatremic levels, so the correction was stopped at mild hyponatremia. And none of these patients achieved normonatremia in the first 48 hours, and there was no sign of neurologic damage. Then they compared these patients' data to those of some retrospective material, 12 patients who had had cerebral demyelinating lesions. And actually the correction rates had been comparable in these two groups, but in the patients with severe neurologic damage, the final serum sodium that had been reached in the first 48 hours was actually normonatremia, or in some cases hypernatremia. So the message, the conclusion by the authors is that it may be actually excessive correction that is dangerous, not necessarily rapid correction. at the beginning. However, in this very same paper, the authors also present a list of case reports that had been published until 1984. And here in the left column, if you can see it, we have the baseline sodium. In the right column, in the middle column, we have the final sodium. And all these figures are actually not hypernatremic. So some of these are mildly hyponatremic. In the right column, we have the mean mean rate of correction. And I added something to this figure. I calculated the mean correction rate per 24 hours, and here we have those figures. And as you can see, in all but a few patients, the correction rate had been well above 12 millimoles per liter per day. Now, there are some newer papers in the literature, but I don't think it's necessary to present those. I guess my opponents probably will. But actually, we already knew in the 1980s everything we need to know about this. So, obviously, when you meet a patient with severe hyponatremia that has developed slowly, that is not hyperacute, it's wise to correct it slowly and to avoid reaching normal or hypernatremia in the first 48 hours. However, there's one question that remains: how should we define very slow? And as Martin wrote already some 10 years ago, all the recommendations for slow correction have been standard for years. What is regarded as slow has actually changed. So in the 1980s or 1990, according to some recommendations, the upper limit of slow was 20 millimoles per liter per day. And then at the other end of the continuum, there's a recommendation according to which we should not exceed 8 millimoles per liter on any day of correction. There are two main guidelines that are often cited, one European one and an American guideline. The European guideline states that we should limit the rate of correction to 10 millimoles per liter for the first 24 hours and then 8 millimoles per liter per every 24 hours thereafter. And then the American guideline states that the limit is 10 to 12 millimoles per liter per day, 8 millimoles per liter per day if there is a high risk of osmotic demyelinative syndrome. And patients at high risk are patients with alcoholism, malnutrition, some other conditions. But then some experts actually recommend even slower correction rates, not exceeding 6 to 8 millimoles per liter per day. In my view, I would say that 10 to 12 millimoles per liter per day is very slow. 6 is slower than very slow, and I'm not aware of any evidence showing that we reach any better outcomes with such an ultra extra super slow correction rate compared to very slow. I'll show one more figure from an interesting paper by Stearns some years ago, presenting patients having extremely severe hyponatremia, so patients with a baseline sodium below 105 millimoles per liter. These are patients at the highest risk of neurological complications. And in this figure here, we have several patients marked in dark circles who had severe neurological complications, and then other patients without complications marked with open triangles. And actually, these patients who had neurological complications had had a correction rate exceeding 12 millimoles per liter in the first 24 hours and exceeding 18 millimoles per liter in 48 hours. So it's wise to stay below those rates. So my conclusion is that all patients with a sodium less than 120 millimoles per liter, they do not necessarily need a ultra extra super slow correction rate, but yes, they do need a very slow correction. So with this, I rest my case and finish with a winter scenery from my hometown, Kuopio. Thank you for listening.